afternoon, everyone. My name is Bayushi Putra from Indonesia, and I'm honored today to host today's discussion. We have the pleasure to interview Dr. Takayuki Kitai, a renowned cardiologist from the Sapporo Cardiovascular Center Clinic in Japan. Dr. Kitai is highly respected for his expertise in device therapies for heart failure and sudden cardiac death, as well as his significant contribution for two innovations in cardiac resynchronization therapy and other device-based interventions. Thank you for joining us, Dr. Kitai. How are you?
Oh, thank you. Thank you for inviting me. Such a great meeting. It's a great honor for me to attend this meeting. Thank you.
Same goes for us. Thank you very much. So, regarding the questions, the first thing is the cardiac device for high-risk patients. In your experience, what are the most critical factors when deciding on device therapy for patients at high risk of sudden cardiac death or heart failure?
Okay, thank you. The main reason for implant ICD is ejection fraction.
I see.
Especially less than 35% in non-ischemic and 40% less than 40% in ischemic heart disease.
Okay.
We should consider all the patients under low ejection fraction patients about ICD implantation or sometimes CRTD.
Oh, okay. So every patient with under 25%, it will be planted for ICD.
No, actually no. So we consider the indication from ejection fraction and the heart failure status, NYHA class 3 or 4, it's necessary, and the ECG monitoring, such as Holter monitoring, shows no sustainability, and we check the indication for ICD.
I see.
Yeah.
So doesn't have to be only the ejection fraction only.
Yes,
we have to.
We start from ejection fraction.
I see.
But in our institution, the sonographer, all check the UCG, echocardiography, and if the patient has low ejection fraction, they report all the patients.
I see.
So to gather the all low ejection fraction patients.
I see.
And okay, this patient is this patient is bad condition, so we consider ICD. Oh, this is ICD.
This is
it's okay. Oh no.
Okay, I see. So there will be some indications that we can use for ICD planted or CRT.
Yeah.
All right. So I think regarding the advancement of the cardiac resynchronization therapy, because as for now we have there is some recent advancement in cardiac resynchronization therapy, particularly for patients with complex or high risk profiles. Is there anything that you can share with us regarding the advancements of CRT? Are there any difference from from maybe 10 years ago compared to now? What's new for us?
What's new? Maybe similar. Maybe
Still
10 years ago and now. So the most important factor is LBBB, left bundle growth, and the wide current complex, and NYHA status. It's similar.
Still similar.
There's no
differences.
Change. Yeah.
I see.
Yeah.
But the device, is there any advancements compared to 10 years ago? I think.
Oh, okay. The every lead has had two bipolar. Only distal bipolar and prox bipolar. But nowadays we can use 4 electrode.
Okay, so you can multi
multipolar pacing. We can it's available, and we choose the distal 1, 2, distal 3, 4 to
determine the best pacing area
and to avoid the phrenic capture.
Oh, All right, I see. So, how do you exactly determine? This one is the best pacing area using the echocardiography, is it, or
Echocardiography and MRI.
I see. So there are multimodal to determine which one is the best pacing area.
Depends on the patient.
I see. I see. So I believe that you have already done several procedures regarding CRTs. What are the most complications you encounter in CRT procedures, and how do you manage to improve this outcome?
So my challenge case is CRT upgrade case. The patient previously implanted pacemaker, and his ejection fraction declined. So we need CRT upgrade.
I see.
In such cases, the subclavian vein was occluded or near occluded.
I
So
see.
we need some intervention to
Dilate.
to dilate the vein.
I see.
So it's the challenging cases.
Okay. So, but while placing the lead or placing the CRT lead, are there any complication that you want to share with us? I mean, the most important thing to be careful for any electrophysiologists out there.
Okay, thank you. And so the most important is to clarify the anatomy of CS, coronary venous system.
Yeah.
That is sometimes difficult to angiogram the coronary venous.
Yes.
We have some cases of coronary venous operation or dissection.
Yeah.
And after that, it's difficult to put the optimal vein.
Oh.
We use the Barman catheter, wedged Barman catheter in the CS proximal and softly shut the angiogram. So,
so that will be the safer. Then I see. But is there any complication before that you have experienced, like CS rupture or something like that?
The rupture and the phrenic capture, and there's no optimal vein there.
Is it a really common complication actually?
No. About 10% of the cases is difficult.
I see.
90% is not so difficult. Maybe easy.
Okay. So, actually, lastly, what future innovations or emerging technologies in device therapy for heart failure excite you the most? The future innovations.
Okay,
that you think that this will be the next big thing.
So in Japan, the patient with difficulty of putting the catheter into coronary sinus.
Yeah.
We choose septal LBB left bundle branch area pacing by RV.
I see.
Yes.
Yeah.
It's the countermeasure for such patients.
So the CS conductance system pacing?
Yes.
I see.
That's like
CSP.
CSP.
I see. So that's the next big thing, all right?
Yes.
The conductance system pacing.
And it's cost effective.
Really?
Yes. Oh. If we change from CRT to conduction system pacing, if the patient has a conduction pacing enough, we don't need CS pacing.
I see. Yeah, that's why it will be more cost effective and will be maybe more battery effective.
Yes.
I see. Yes. But will it replace CRT? Will it replace CRT?
Yes.
Ventral pacing?
Yes.
I see. Okay. Lastly, do you have any maybe closing statement for us for the future cardiologists or for
okay. So we in Japan we have many cases of atrial fibrillation ablation and device implantation. So please come and see our institute. And
thank you very much.
Yes.
Yeah. Thank you very much.
Thank you so much.
Thank you very much, Kitai. Yeah. Goodbye. See ya.
See you.